everybody, and welcome to one of the summer's conversations with a doc. Tonight, we're so lucky to have Dr. Cynthia Fields, who's going to speak on care partners and managing challenging behaviors. Dr. Fields is an assistant professor in the Department of Psychiatry and Behavioral Sciences at Hopkins. After completing her residency training in Tulane in New Orleans, she returned to Baltimore to pursue her fellowship training at Hopkins. She is board certified in psychiatry, geriatric psychiatry, behavioral neurology, and neuropsychiatry, and her clinical interest is in the psychiatric complications of neurological diseases. And with that introduction, I'm just going to turn it over to Cindy, Dr. Fields, and take it away.
All right, perfect. Thank you, Judy.
I'm sure.
Cynthia Fields, Judy gave the intro. So disclosures, no relevant financial disclosures. A few disclaimers about my talk. So obviously persons with Parkinson's disease are individual, right? So I'm giving these sort of broad sweeping recommendations or insights and such, but they don't always apply to an individual. I hope that at least some of what I say will apply to each person in this audience. And so we talk about the concept of person-centered care, and that's exactly what that is. So recognizing that while there's a constellation of symptoms that we define as Parkinson's, any one individual will have some unique combination of those symptoms and present with them in some unique way. And in this talk in particular, I'm going to be focusing on you as the care partners and people in the audience who have Parkinson's. I'm not going to be talking about medications, like that's what the doctors do, right? I'm going to talk about really what care partners can do to prevent behaviors ideally and also to manage them. And then I'm not here to provide medical advice, right? Like I'm teaching about something, but not weighing in on individual people with Parkinson's as patients. And I'm going to make some meaningful points, but it's not all inclusive, right? We have 30 minutes. And what I gave a lot of thought to is what are the challenges that I see in my clinical practice most often? And so that's how I went about it. And so just to put this in context, there are the motor or movement symptoms of Parkinson's, and then there are the non-motor symptoms of Parkinson's. So movement, motor, non-motor. And this is a list, also not an exhaustive list, but just to put it in perspective. So in the non-motor symptoms of Parkinson's, we have autonomic dysfunction, things like constipation, pain, fatigue. And then the rest of the list that I put in yellow, those are kind of the subheading of neuropsychiatric symptoms of Parkinson's. So that's what I treat as a psychiatrist. So I'm treating the psychiatric manifestations of Parkinson's. And so sleep problems, the neurologists help with that very much. So that's a little bit of neurology, a little bit of me. Impulse dyscontrol, we can see in Parkinson's. Anxiety, depression, apathy. I've given a talk on anxiety a couple of different settings. Psychosis, so that's hallucinations, delusions, paranoia, and then cognitive impairments. And so a lot of what I'm going to be talking about tonight, we're going to be looking at challenging behaviors that result from cognitive impairment, not exclusively, but a lot about cognitive impairment. And then I'm weaving in some of these other concepts in yellow. So in terms of cognitive impairment in Parkinson's disease, it's very common and it does tend to fluctuate. Much like those movement or motor symptoms fluctuate, cognition fluctuates as well. And I think that most people just really aren't aware of that. And in Parkinson's, the cognitive impairment that we see, it's typically more about thinking rather than memory. So changes in thinking and sort of processing information can become more challenging. And that happens earlier on. And then as Parkinson's progresses, some people also develop frank trouble with memory and recall. But what we often see are much like movement is slowed. We see slowness in thinking, trouble with attention and concentration. People can get distracted very easily. I suspect that many people in the audience have observed that, and it can be really hard to multitask. We see a lot of executive dysfunction, and that's trouble with like reasoning, judgment, problem solving. And then in terms of like a spectrum, there's mild cognitive impairment, meaning that someone has changes in thinking and or memory, but they're still functioning independently and functioning quite well. And then over the years, the longer that someone has Parkinson's, they're at increased risk of not only mild cognitive impairment, MCI, but then also progressing into dementia. And when I say that someone has dementia, what that means is that not only do they have trouble with memory and thinking, but they also are having changes in their function. So some functional impairment. Maybe that's driving, maybe that's medication management and such. And it's functional impairment because of changes in memory and thinking, rather than things like tremor that affect handwriting. So if I have a patient with Parkinson's who no longer pays the bills because his handwriting for checks is hard to read, that wouldn't be a cognitive change, if that makes sense. So really something in terms of memory and thinking is what we're talking about. And then if someone with Parkinson's develops dementia, they're more likely to have these neuropsychiatric symptoms that I mentioned. So things like psychosis, as an example. And I just want to put in a quick slide because the nomenclature is a bit confusing. I wanted to mention specifically dementia with Lewy bodies. So there's a bit of overlap and it's a bit confusing, but there's Parkinson's with dementia. So over the years, someone with Parkinson's can develop dementia. And then there's dementia with Lewy bodies. And so what that means is the cognitive changes came first, and then the motor symptoms of Parkinson's. It's not actually in real life that simple to distinguish the two, but a lot of it is about what came first. And in dementia with Lewy bodies, we see a lot of visual hallucinations. We see pretty dramatic changes in, that's supposed to say fluctuation in attention and cognition, not attention and attention. And then oftentimes in DLB, people have early troubles with walking and imbalance and falls. But I'll mostly be talking about Parkinson's disease with dementia, but there are a lot of similarities. And so a while back, I gave a talk specifically about Alzheimer's disease. That's been most of my career, has been Alzheimer's disease and the behavioral changes that come with that. And I gave a talk a while back, and I called it my pearls talk, right? Like 10 clinical pearls about Alzheimer's disease and dementia with behavioral disturbance. And so I had this talk and people, just seemed to go over really well. And so I thought, well, can I modify it for Parkinson's, and like what do we know about that, and what's the literature base? And so I took these clinical pearls and I modified it to be more specific to Parkinson's, and realizing that cognitive impairment has a greater impact in terms of socially and occupationally, has a greater impact on functioning. So the cognitive impairment in Parkinson's has a greater impact on functioning than Alzheimer's alone. And I hope I said that correctly. But when you think about, by the time that someone with Parkinson's has clinically significant cognitive impairment, in all likelihood, they've had Parkinson's for a number of years, and all of the physical changes that go with that. Because in an Alzheimer's type of dementia, oftentimes physically, people are quite mobile and move around quite well until later in the disease. So there's a lot of overlap in terms of behavioral and other neuropsychiatric symptoms. But in terms of sort of the burden, the functional change, it's just much higher in Parkinson's because of all of the other movement pieces that come with it. That was just an article that helped me to know that I was on the right track. And so the first of these 10 these 10 pearls, is to recognize that needs change. And that literally is a moving target. I know you guys picked up on that. But to realize that cognitive impairment is a moving target, there are differences in cognition and function in the on phase, like on versus off phases of the carbidopa-levodopa of the Parkinson's medications. There are changes in terms of the day, like what works for someone well in the morning might not work later on in the evening, might be more challenging. It's the same task, but it could be more challenging later in the day. And then it really is a thing. It's not just a cliche, this concept of good days and bad days. So I know that you all know that in terms of Parkinson's and the movement piece, but also the cognitive piece and emotional piece, good days and bad days. And in terms of prevention, one really important piece is to have a daily schedule. And I know that that can be hard to implement because you don't know how the day is going to go. You don't know how it's going to go one day to the next. But in general, to have some daily structure, some structure, some routine, that makes things easier for all of us. That's not unique to Parkinson's and that's not unique to cognitive impairment. But have some piece of sort of a daily grind that we don't have to think about, that's familiar, and we just do. Makes a big difference. And we think about the trouble with kind of thinking and planning and organizing that you see in Parkinson's. It's really hard as Parkinson's progresses for that person to come up with a plan of what they're going to do and then to actually be able to accomplish it. There's so many barriers, like including things like apathy and such. And in that daily schedule, physical exercise, and I know that neurologists like beat this into everyone, and I'm so glad, because not only is the physical exercise important for the movement symptoms of Parkinson's, the motor symptoms, but physical exercise is incredibly important for cognitive health. Like more and more, just general cognitive health and dementia, we're learning how physical exercise, that's what people can do to help stave off cognitive decline, and then to help once they have cognitive impairment to try to slow that down. So putting in physical exercise into the day is quite important. And to try to match tasks of the day to the better times of day, right? Like harder tasks to the times of day that generally are better for that person. And I'll hear things in my office like, oh, after he takes his 11 o'clock Cinemet, he's really good from 11:30 or 12 until 2 or 3. So to use that part of the day to do tasks that are challenging. Don't leave that challenging stuff till later on in the day if that's a time when it's hard for that person to think clearly and function well, because that just leads to a lot of frustration. And the evenings for many people with cognitive impairment, the evenings are difficult. And we talk about sundowning, and that's a term that's often associated with Alzheimer's disease, but it's also useful in Parkinson's. And the concept is, not only are like the visual cues less, but literally there's brain fatigue. There's body fatigue and there's brain fatigue. And especially if it's been a busy day. And that's challenging because you want activity and you want stimulation, but then there's this fine line, and I can't tell you exactly what that is for each person, but there's this fine line where activity and stimulation becomes overstimulating and exhausting. And so we can see after that in the evenings, we can see more like confusion, sometimes more anxiety, agitation, and just sort of behavioral issues. So finding that balance is a challenge. And it is okay. It is so okay. It is so encouraged to lower expectations on a bad day or a bad part of a day. And so when I talk about structure and routine, it's not something that has to be hard and fast, but general, so that someone knows what to expect. And along with routine and structure, I'm going to come out heavy from the gate and mention sleep. And I know people in the audience are struggling with sleep. So sleep problems in Parkinson's are extremely common. And you all know that they're bad for cognition, right? For anyone. That's not unique to cognitive impairment or Parkinson's, like for all of us. It's hard to think clearly and manage anxiety and emotions and behaviors when we're sleep deprived. And fragmented sleep is really common. So waking up a lot during the night or can't turn over, uncomfortable, confusion overnight, all of these things, needing to get up and use the restroom, all of these things fragment sleep. And then there's also like the REM sleep behavior and restless legs, EDS, excessive daytime somnolence, lots of other diagnosable things happen with sleep. The biggest, and I put it in bold because it's super important, the biggest piece of advice I can give about sleep and structure and daily routine is to get up at the same time every day, especially if you didn't sleep well the night before. Because what happens is somebody didn't sleep well, they sleep in later, then they're not tired at night, and then they sleep in even later. And then before you know it, I have patients who are going to bed at 2 a.m., 3 a.m. or more. And if that's the schedule that you want to keep, that's okay. But for most people, that schedule doesn't work. And so really to pick an 8-hour window of sleep and stick with it. And literally do the math, right? So you got up at 8 a.m., you can expect to go to bed at midnight and then sleep ideally from midnight to 8. But getting up at the same time is incredibly important. And morning sunlight, that's a bonus, right? And there's really something about the sunlight. We're talking really like biologically, evolutionarily, where the sunlight hits the back of the eye, hits the retina, and it's good for mood. It's good for sleep-wake cycle regulation. It just has so many benefits. So if you can get some morning sunlight in, even better. Power naps, that's fine. Anything longer than 30 minutes, we get into that deep sleep where people wake up kind of disoriented and kind of logy. And it really does take away from the nighttime sleep. So power naps, that's a great recharge, but really less than 30 minutes, ideally more like 25. And then to have a bedtime routine with signals, right? So literally kind of turning down some of the bright lights, staying away from electronics, having some kind of sleepy time tea, whatever it is, kind of washing up, but some signals that really let the brain know we're winding down and we're going to bed. It's huge. Sleep and behavioral problems, it's huge. And we're thinking in terms of prevention, right? And so here, this goes into more of what do you do if the person that your loved one, the person that you're caring for, is having some behavioral issues. So of this 10 pearls, and these go shorter than the first couple. One of my biggest rules, don't argue as much as you can. And so I'm talking about cognitive impairment. As cognitive impairment progresses, misremembering and misinterpreting things, I mean, they happen, period. Also not unique to Parkinson's or to cognitive impairment. But if someone does have more cognitive decline, and particularly if they develop dementia, they will misremember events and could misinterpret something in the environment or misinterpret something that was said. And in those cases, someone already has cognitive impairment, already has trouble processing information, arguing and giving them more information. And when they have executive dysfunction, like the trouble figuring things out and reasoning and judgment, asking them to do more of that is not helping. We think of it that way because that's how we're used to communicating, right? Like challenge one another, we argue, we do some back and forth. But if someone already has some confusion, that's just a way to make them upset and frustrated. And so what you want to do is to validate. And I think sometimes people get these things mixed up, right? They can validate the emotion without truly saying that the content is accurate, right? So, and I'm just trying to think of an example. We'll talk about wanting to go home later, but any situation where someone insists that something is the case, does it really matter if they don't believe the correct details? That's okay. And so what you want to do is validate, like, I see that you're upset, and then maybe redirect or reassure, go on to something else. But arguing the point when there's really not a purpose, it's not a court of law, just doesn't make sense. And the goal is to de-escalate. So if I have someone with cognitive challenges who's getting more and more upset, I don't want to get upset with them because I'm showing them that there's something to be upset about, right? If I'm getting anxious or if I'm getting huffy, I'm showing them that there's something to be upset about. And I want to do the opposite. So as they're getting more upset, I'm getting less and less completely calm and flat. And I'm agreeing until the moment passes. It's really important. And it can be hard to do. It can be hard to let someone say things that are untrue. I see it in my office often. And I know I have a pretty good idea of what's accurate and what's not. And it's just okay. Really, it's okay. And along those lines, our need to correct one another. So in Parkinson's, we can see changes in judgment, impulsivity. I'm going to talk about impulsivity in a moment. And my biggest advice is to pick your battles, right? In terms of safety. And I put this sort of little tongue in cheek, I never run with scissors. Like the last two words were unnecessary. That's an ode to my inability to exercise in recent days. But like running with scissors, like a classic, just if it's a safety issue, it makes sense to correct. But otherwise, as much as you can, just let it be. And for those same reasons that, we don't like to be corrected. And oftentimes if someone with cognitive impairment is doing something that they shouldn't be doing. I'm just trying to think of an example. They want to wear something that whatever, or they want to sit somewhere, they want to do something, touching something they shouldn't be, whatever. If it's not a matter of safety, the suggestion is to let it go and to try to be okay with that. Because the correcting, especially if someone doesn't understand the reason that they're being corrected, all that does is just sort of leave a bad feeling. And I think that it's important to remember that people with Parkinson's are adults, right? They're adults who are forgetting. And I think that sometimes because of role reversal and such, it feels like maybe because somebody's acting childish, you should correct them, but they're adults. And so as much as you can to pick your battles, and if it's not safe, you try to leave it alone. And I know that might be an unpopular opinion, but it really does make life easier. And I mentioned about impulsivity and Parkinson's. So we see changes in judgment, safety awareness, people really feeling, it's seemingly like compelled to do some things and sometimes to do them over and over again. And one of the ones I see in my office a lot is frequent standing up and walking, even though it's not safe, even though this person needs assistance with walking, they need to use their walker. They don't have their walker with them. And my advice is for this frequent standing up and with the potential to fall is to try to lessen the need for standing up. So maybe that is frequently taking that person for a walk, or try taking them to the restroom every 2 hours, because maybe that's part of it. To try to kind of decode what's the reason that my person keeps standing up. And if I intentionally schedule standing up and try to meet their needs, maybe that might happen less. Maybe it won't work, but sometimes that does. And to utilize visual cues. So I might hear in my office, he never takes his walker with him, and then he gets up to stand up. And so I might say, well, if he forgets his walker, why don't you go and get his walker and put it right there in front of him? Or sometimes if someone is sitting with an empty lap, it's kind of a signal, oh, I'm ready to go now, I'm going to get up. So sometimes an activity on someone's lap, or even one of those lap blankets, with something sort of on their lap, engaging their hands. It's just sort of a human nature. You have something in your lap, you're kind of sitting and you're staying. So maybe that might lessen the need. And my point of these suggestions is thinking in terms of prevention rather than reacting, like sit down. Because that also, there's something about human nature, right? We're told to do something and perhaps we want to do otherwise. And there is a behavior unique to Parkinson's that we call punding. It's sort of repetitive, purposeless behavior. Oftentimes it might be like, or feels purposeless, but for the person doing it, it has purpose. Assembling or disassembling, taking things apart. So perhaps to be intentional about it. And if you know that your person likes to do that, to give them something that they can assemble, disassemble, that's not going to ruin something important. And a little bit about confusion and indecision. So this executive dysfunction, this trouble with making decisions, that happens early on. And so the idea is to set someone up for success. And so something I hear in my office from time to time is, I ask him what he wants to do and he says he doesn't know. You think about open-ended questions. So for an open-ended question, you need to remember what all of your options are and then prioritize them and choose one. And what we know about cognitive changes in Parkinson's, that's hard to do. Both of those tasks are hard to do, to remember options and to prioritize and choose. So if you know, or like, what do you want to eat? That's another one. So if you're at a restaurant and you know that your person likes the chicken and the hamburger, say, hey, are you going to have chicken or hamburger? Rather than, what do you want to eat? So if you can try not to use as many open-ended questions and give choices, 2 choices, and sometimes, depending on the moment, sometimes it's even hard for someone to choose out of 2 choices. So we talk about setting someone up for success. And I put this picture because I imagine she's choosing paint colors, something that's incredibly frustrating. So even seemingly small decisions can sometimes be hard. And along those lines, so number 5, like visual cues are really important. And that also in activities of daily living, like putting those 2 things together. So those are also choices to make, right, in the environment. And when someone has slowed thinking of Parkinson's, right, trying to get from A to B, it's so easy to get distracted. It's like the long road, and so much can happen before that information gets to where it needs to be. And so people with Parkinson's notoriously are easily distracted. And so one way to help someone to function better is to simplify the environment so there aren't so many distractions. And so things that someone is supposed to be using or doing are right in their field of view. For all of us. I mean, I have reminders sitting on our desks. That's not a unique thing. So to eliminate the choices, and we talk about this concept of cognitive load, you want to set someone up for success and make their functioning easier. Because you can, one of the circumstances where we see behaviors develop is where there's this mismatch of what we're asking a person to do when they have cognitive impairment and their ability to do it. And so we're trying to simplify tasks. And that's particularly important with things like activities of daily living to help someone stay as independent as possible in the face of cognitive changes and functional, like physical limitations. And when I put the toothbrush thing here, I've literally had this conversation a couple of times in my career. Someone using the wrong toothbrush, because hello, all toothbrushes look the same. And especially if it's in the evening and someone's not thinking clearly, or like using, shave cream as like, toothpaste or something, these mix-ups that happen. So you want to just give someone one choice, right? One toothbrush. And if you want them to shave, if it's the time to shave, it's the shave cream and the razor that's supposed to be used. In the shower, a shampoo and a bar of soap, but something where it's almost hard to mess it up. And we see this like decision-making, confusion, distractibility, processing information, difficulties. We see that a lot linked to anxiety. And I do a lot of anxiety work. And we know separate anxiety is a huge unmet need in Parkinson's, incredibly common. When we think about anxiety as like fear and worry, those are kind of the general concepts, right? Like fear about something imminent, I'm scared, and then worrying about things in the future. And I listed some of the, some of the associated conditions, panic attacks and such. But anxiety and cognitive impairment, it can be really hard for me as a professional to tease them out, like which came first. So anxiety makes it hard to think and figure things out, like as evidenced by me giving this talk, right? But anxiety makes it hard to think, and then trouble thinking and figuring things out makes people incredibly anxious. And it can happen all at once. And what seems like a simple task, even just like, putting on shoes and socks, or pulling up a password, like logging into email, or just a number of tasks, they seem simple enough on the surface, but when someone with Parkinson's and cognitive trouble starts to have difficulty with that task, they can get so flustered and sometimes incredibly frustrated and even angry. So what was simple in a given moment on a given day might not be simple. And the other piece that we see is that someone can very quickly, not very quickly, but like early on in cognitive impairment, can really lose confidence in their ability to do things. And so I see this a lot with traveling. I'll have someone who used to love to travel, and they have Parkinson's, and they, because of various difficulties, lose confidence in their ability to handle travel, or handle going out to a restaurant, or handle going out to a family gathering. And so what we try to do as much as we can in terms of cognition is to try to lessen the cognitive load to make these tasks, and I use that term broadly, tasks, as easy as possible. And, you want to acknowledge the anxiety, and you want to acknowledge the discomfort. I think it's tempting to be like, there's nothing to be anxious about. But sometimes that just makes the person with anxiety feel like they're not understood. So that's not always helpful. But acknowledging the anxiety and saying, this is how I'm going to help you, and we'll do this together, and be more effective, and there's nothing to worry about. And then moving on to resistance, I suspect some of you in this audience have encountered resistance. That's often to things like, dressing, bathing, toileting, changing clothes, like just those sorts of tasks. And even though they're in somebody's best interest, there can be resistance there. And I equate that to nobody likes to be told what to do, like even if we need it, right? And oftentimes, by the time that someone with Parkinson's and cognitive impairment needs a certain level of help, sometimes they might not realize just how much help they need. We call that insight. And as someone develops, mild cognitive impairment into dementia, oftentimes people underestimate the difficulties that they're having, or overestimate their abilities. We see that with walking. Like I can do this myself, getting up and walking. And so one of the ways that we try to overcome resistance to help is to try inviting the person to do something. So rather than, it's time to take a shower, or you need to get up and change your clothes. More of an invitation, more of a let's. And if someone's not willing, to give them time to process that and to come back later and reapproach. And sometimes, especially if someone is having more short-term memory loss, it can be a totally different encounter, a totally different experience. So that coming back again. And once again, this is that piece of person-centered care, right? As much as we can, I mean, obviously within reason, but as much as we can to kind of have the task fit the person rather than making the person fit the task at that moment. And a little bit about agitation, unprovoked, I say, right? Because the slide that we just did about resistance, sometimes forcing the issue, once again, choosing your battles, but sometimes forcing the issue can result in agitation or even sometimes aggression. But sometimes agitation just can kind of come out of nowhere, and it can very much feel like what is that about? And so I love this concept of unmet needs. And I have a chart on it for the next slide, but unmet needs. So, and this is typically later on in cognitive impairment and in dementia, where maybe somebody, or maybe they're sundowning or something, but where somebody's unable to communicate their needs. And that might come out in agitation or even aggression, anger. And so I love this concept of this triad of like, is it physical? Is it emotional? Is it environmental? And I'll show you a slide on that. And I do want to mention, like, along these lines, like also to just in the moment, if you're seeing unprovoked agitation and you're trying to do this detective work, right? Like, is it physical, emotional, environmental? To also just do a check-in with yourself. And are there any caregiver factors? Like, am I exhausted and sleep deprived? And I don't even realize that it's showing on my face. Right? Because it very well can be the case that you're not asking your loved one to do anything, not telling them to do anything, not anything. And then there's this agitation, but especially as people have more trouble with language, like spoken language and understanding language, that the nonverbal cues, they become the most important. And we're not good, most of us aren't good monitors of our affect, right? And the nonverbal cues. And here, like, that's a psychiatrist saying it. But you know, things show on our faces. And so just to do a check-in. And I put this this little hangry, like apologizing for what she does when she's hangry. Like, hunger is real. So this is a great chart. And so some examples of medical pain, discomfort, and pain. I think that we under-recognize and underappreciate pain in Parkinson's. And I try to remind myself how to have such stiffness so much of the time and such challenge moving where everything is effortful. That makes sense to me, that would hurt. The pain is a known complication or symptom of Parkinson's. We talked about sleep, you know, other medical conditions, sensory impairment, like not being able to see, somebody not having their glasses or not being able to hear can be triggers for agitation. Talked about anxiety and fear, worry, talked about frustration. Boredom is another one. That somebody just needs to be occupied. They need some interaction. Then there's a whole list, some environmental, you know, is it too hot? Is it too cold? Is it overstimulating? Sometimes something that I see in my practice is perhaps I'll have someone who loves their grandchildren incredibly, but perhaps now where their Parkinson's is and where their cognitive impairment is, it's too much to have a room full of the grandchildren playing and being loud. It's too much. And it's not that person doesn't love the grandchildren. It's just, it's overstimulating, it's overwhelming, it's a lot to process, it's confusing. And so sometimes the environment needs to be modified. So something like that, maybe 1 or 2 grandchildren at a time, but not everybody. So you have to think of, as much as you can, like workarounds and ways to do the same activity, like seeing the grandchildren, but not all at once, if that's possible. And then this is a big one at the bottom, about somebody's ability. And I feel like we've been talking about that all along, like matching the task and what you're asking someone to do to their ability to do it. at that time of day, in that setting, all of those factors. But that task ability mismatch, I mean, it's really, I think for many of us, can be incredibly frustrating. You think you should be able to do something and you can't. I mean, that's upsetting for me. So that just makes sense. And we're almost at the end. So disorientation, oh, well, Back to the Future, right? Like this is how it strikes me. We talk about in dementia, we talk about time travel, basically, right? Like later on in dementia, you know, in some ways your loved one has become a time traveler. And so sometimes I'll have someone looking for their parents or looking for their children, but they're thinking of their children when they were young, right? Not as, 60-year-old adults, or maybe someone's doing some time travel and they think that they're still working. And so they get up at 4 a.m. and get ready for work because they've always gotten up early in the morning, gotten ready for work. So in that setting, that makes sense to me. If that's where that person is at that moment in time, they're back some decades, they're working, so they're getting ready for work. I had a care partner give me a great solution. She was like, oh, I just tell him, oh, it's Saturday, you get to go back to bed. And for him, that worked. And it can be helpful to reorient someone, but if that doesn't work, if telling them, this is 2024, I'm your wife, blah, 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 if that doesn't work, my best advice is we talk about getting on the bus, right? Like, go with it. Because the proving to someone who's already not thinking clearly, they're already confused, they're not remembering in that moment, to prove to them with pictures or birth certificates, marriage certificates, all these things, like it really just ends up in a lot of frustration. And it tends to go better to go with it. And we see that asking to go home, I mean, nobody really knows what that home is. I heard an interesting talk that addressed some of these issues. And, one of the ways that this couple they were giving the talk, one of the ways that they described home is like the feeling when we think of home, that positive connotation, that sense of like familiarity or comfort. So maybe that's what the person is looking for. Or maybe they're doing the time travel and they're thinking of their childhood home. It's hard to know. And the approach that this couple gave, which I've since adopted, that I really appreciate, is this concept of yes and. So agreeing, acknowledging that they want to go home, and can I get you a cup of tea first? And how about if I sit with you while your ride is coming? So some acknowledgement, so you're not arguing that they want to go home, they want to go home. I mean, that home, like they are home. But the point that I'm making is to validate the emotion behind it. Like the facts don't matter here, but it's the emotion. And that people are often looking for reassurance. And so I try to think of things, and I don't remember if this is in my next slide or not, but when I have a mother who's looking for her children or believes she needs to pick her children up from school, I try to imagine if I were in that position, how frightening that would be. You can't find your children. You think you have small children, you cannot find them. So to try and imagine what that would be like, and then to address the emotion behind it. And if you were in that position, what would you want someone to tell you? Therapeutic lies. So this leads in. So when someone is having confusion, in my next slide, I talk a little bit about psychosis. Someone's having confusion or some false beliefs. Sometimes lying is the kindest thing to do. We call those therapeutic lies. And they're our attempts to help someone feel better in their reality. It can be hard to do depending on the relationship. I find especially couples that have been married for many, many, many years, and lying has not been a part of what they do, that to have to tell a spouse something untrue because they're confused or they're agitated or they're anxious or whatever. It can be a tough sell. It can be hard to learn. But my point in that is that we all need reassurance. And so, especially those sundowning times where somebody's having more confusion, or they think they need to be somewhere else or home or whatever, like they need reassurance. And so the trick is to figure out how to meet that individual person's needs at that time. And there's no one size fits all. And psychosis and Parkinson's, and I'm almost done. Psychosis is common, especially in the later stages of Parkinson's and Parkinson's with dementia. And so psychosis are hallucination, so visual hallucination, seeing things that aren't there at all, and then illusions. Illusion might be like, I have a coat rack with a coat, and so that looks like a person standing there by the door. So there's something there, but I'm misinterpreting it. Well, we often just call it all hallucinations. And oftentimes, people with Parkinson's will see, like people or animals. That's a common one. Sense of presence is pretty unique to Parkinson's. This feeling like the weight of someone's stare, this feeling like someone's there and nobody's there. Passage hallucinations, something just whipped by, might think you have mice or such. That's fairly unique to Parkinson's. But hallucinations are quite common, and we try to manipulate the environment as much as we can for those. So if that coat rack looks like somebody standing there, get rid of the coat rack. Pillows on the sofa, I've seen that quite a few times. Pillows on the sofa look like somebody's laying there. Get rid of the pillows. And really to declutter, because all of that stuff around can be misinterpreted as something else. And lighting is really important. So shadows and such just make for a vivid imagination. And then delusions. Delusions are very challenging for care partners. There are whole articles about how hard these are to handle. And so delusions are these fixed false beliefs, and oftentimes they're like of a paranoid nature, right? That something bad's going to happen, or you're trying to do something bad to me. And we also see these, they're not well categorized, but these misidentification delusions, like you're not my husband, or like more than one of you, these reduplicative, like the other house or the other Fred or something. They kind of morph, but it's this idea that you're not who you're supposed to be or who I think you are. And those can be incredibly painful. And I don't have, other than the strategies I've mentioned before, I don't have a great strategy for that. It can try reality testing, right? No, I am your husband. But if it doesn't work once, maybe twice, as much as you can to get off of that topic. And as much as this isn't a talk about medications, I find you use all of the different behavioral interventions you can, but when it's full-blown psychotic symptoms with delusions, especially if that makes that person agitated or aggressive, angry, agitated, aggressive, then that may be a spot for some medication adjustment, maybe coming down on carbidopa-levodopa or a little bit of an antipsychotic medication, but they can be really challenging to treat. But that's a special challenge, those delusions. Where did that come from? It's not a one-person job. I think that belongs on this slide. Had its own slide. I guess that means it's especially important. So the last, caring for the care partner. And I put this, you can't pour from an empty cup. And I feel like a lot of the feedback that I get, and absolutely right, is like being told you need to take care of yourself when there's not a way to make that happen. And I guess I'd like to hope that there is a way for everyone to get some kind of help or some kind of relief, and I don't know what that looks like, and maybe that's not possible. But I think the first step is acknowledging that it's really necessary, that it's not a one-person job. When we see depression, we see anxiety in care partners, insomnia, that's a big one. And that whole sleep disturbance thing, that's, that will really lead to some burnout quite quickly. And I want to mention, we talk about grief. So even though someone with Parkinson's with dementia, even though clearly they've not died, they're here, there can be a real grief associated with seeing someone decline and having a series of losses, these sorts of milestones and changes. So we call that anticipatory or pre-death grief. There's not a great term for it, but it exists. And I mentioned it's not a one-person job. And so I am so glad that everyone in this audience found MAPS. Judy and everyone are amazing for support, and that you were able to be here. And time for questions. And I think I can probably stop my screen share. Oh, shoot, it's 8 o'clock already. Is somebody else talking? I think you guys are on mute.
Cindy, Dr. Fields, you don't turn into a pumpkin, do you?
I don't. I just
Okay,
feel
we're
like
all right
everyone. I
then.
have nowhere to be. I just feel bad that I
Okay.
can't on.
We're okay. We're okay. So I've got questions from people that were submitted earlier. The first one is, how do I find time for companionship with my spouse when performing a multitude of necessary new tasks, as well as my former ones, and in addition to the daily prompting my spouse to be independent by selecting preferred activities and exercise?
That, and I swear everyone in the audience, I did not know that question before I gave the talk. Something that I recommend often to my patients and their families is, if there's anyone in your support network that you could accept their offer of help. I feel like there's often a mismatch that I hear being outside of the actual person with Parkinson's and their care partner being outside of that. I feel like I often hear people offering and being willing to help like grown children, but then the care partner not wanting to bother them or something along those lines, but not taking them up on their offers to help. I literally see it in my office. I see a mismatch there. And what I recommend is to ask for something, to accept offers of help, and to be specific in what you ask for. So things like, just as a random example, right? But like on Friday nights, I'd like to be free to pursue X. I don't even know that you need to say what X is. And like for my patients who have grown children, I'll make a suggestion like, everybody get out the calendar and talk amongst yourselves and figure out your Fridays. Like, get pizza for a Friday, but some time and some time of day, some span of time, like that makes sense, like during which you could reasonably be gone without too much interruption. But to seek help and accept offers of help, but to be really specific. I'm convinced that people genuinely want to be helpful and they don't know what to do. Mm-hmm. And so I think it's the care partner's job to let them know what that is. And I don't mean at all to make it sound easy. And I honestly don't know how people do it. It's incredibly challenging.
Okay, next question. Can someone with PD stay at stage 1?
Stage 1 in terms of, Judy, do you think they mean motor symptoms or they mean cognitively?
Well, I would think the answer is, since Parkinson's is a progressive disease, the answer is no.
Yeah, I mean, I think I'm not entirely exactly sure what that question is referring to, but in terms of cognition, which is largely what I've been talking about, a proportion of people with Parkinson's over the years develop clinically significant cognitive impairment, but not all of them. And I definitely have quite a few patients in my practice who have had Parkinson's for a number of years. And for whatever reason, I don't know if it's, if it's something that they're doing or just how Parkinson's is manifesting with them, but they've had minimal cognitive change over the years. But I always recommend things that we talked about, exercise and things like cognitive stimulation, socialization, good diet, sleep, all of that, hydration, all of those things, to really make those things someone's job. But it's not inevitable that someone will have mild cognitive impairment or dementia. But I'd say that most people with Parkinson's have noticed some changes, but like the confounder is that they also tend to be older. And so most people in that similar age group are also having trouble with word finding difficulty, trouble with multitasking and such.
I'm not talking about that.
I'm going to be 50, Judy, so I get it. Totally get it.
Here's another one. Can the speaker please talk about pharmaceutical approaches to managing agitation and aggression? What are the differences in frequently used drugs and the pros and cons of each?
Yeah, I can give you some kind of general principles in that area. So typically we start with antidepressant medications. So antidepressant, that's a bit of a misnomer because those medications also help with things like anxiety or irritability. So some examples would be like sertraline, which is Zoloft, or Lexapro, which is escitalopram, venlafaxine, Effexor. Those are some examples of the ones that we use commonly. So oftentimes, if a medication is needed, we tend to go the antidepressant, anti-anxiety route because those are safer, inherently safer. I mean, I don't know what's the latest statistic, how many Americans take antidepressants. Like, let's get real. Like, that's a really common medication. So considered safe, and that it treats a multitude of symptoms. And that things like anxiety and depression are so common in Parkinson's. So usually that's where we start. And then sometimes people need antipsychotic medication. So those would be medications like Seroquel, which is quetiapine, or olanzapine, which is Zyprexa. Those are some examples. And so those are antipsychotics. So they fight like hallucinations, delusions, paranoia. And those medications were developed for schizophrenia, where people hallucinate and have paranoid delusions and such. But we use really low dosages in Parkinson's. And they can often, perhaps they don't take those symptoms away completely, but they often take the edge off. And I find the same thing with the antidepressants that we use, even though theoretically an antidepressant shouldn't make a difference with a hallucination, but they have a way of sort of taking the edge off and being like that those symptoms are more manageable or more tolerable. And then the other category, sort of like it's quite unique, is Nuplazid or pimavanserin for Parkinson's related psychosis. That has its own FDA approval. In my clinical experience and talking with my colleagues, the pimavanserin or Nuplazid hasn't, although it can be effective, it hasn't been the game changer that we thought it would be. I think like we were hoping in the field that it would just be so amazing for these symptoms, but helps some people, but others it doesn't. But the psychotic symptoms can be challenging. And the other piece that I want to mention is that there's a trade-off with carbidopa-levodopa, right? Like Sinemet, Rytary, the dopamine, because you want to give someone with Parkinson's dopamine because you want them to move. However, other parts of the brain that are responsible for things like hallucinations, those are also triggered by dopamine.
Hmm.
And those medications that we use for schizophrenia, that we use in low dosages, like the Seroquel and such, those are anti-dopamine. It's just a matter of sort of what area of the brain, and everybody's close together, right? Like what little brain receptors the dopamine is pushing on. So you want it to push on the brain receptors for movement so that you can move, but inevitably they're going to push on the brain receptors that make people psychotic. And so there is a trade-off, and there are these, generations of medications and such, and you hope for good, more for the movement, less for the other. But it's a trade-off. And so sometimes we end up decreasing the carbidopa-levodopa, and that lessens the psychotic symptoms or could lessen impulsivity, like I talked about. But the trade-off is that someone might not be able to move as well, unfortunately. But that's a great question that you asked.
You probably have answered this, but I'm just going to ask them all. What do you do when a person is combative?
Yeah, I think I kind of touched on that, but that's a really direct question. The best thing, as much as you can, to be hands off and de-escalate. And that might mean that that person falls. It might mean that that person tries to walk out of the house. It might mean something like that, but you're trying to avoid a really physical altercation where someone could get seriously hurt. And that's probably not the best answer, but the idea is that as much as you can, as they get more upset, you get less upset and try to remain safe as the care partner, to try to remain safe. And I absolutely have had situations where my patients have, for whatever reason, and maybe they had a urinary tract infection or just something random, and all of a sudden they were more confused and agitated and aggressive. I 100% support the care partner getting out of the way, even if that means that there was a fall or even if they wander, then you call 911, or then you drive the car and follow them. But you don't want to put yourself in the way of serious harm like that. So kind of hands off and less is more is probably the best answer. It doesn't cover all situations.
Okay, I know you covered this, but I want to go home. What's the best way to respond? And again, what to do for combative behavior?
So that I want to go home, probably the thing not to do more than once is to say that you are home. Because clearly at this moment in time, the person with Parkinson's is not recognizing, and there's nothing you can do in that moment to get the person to recognize that it's home or believe you. So some of the things that, I think I mentioned a couple of the strategies, but sometimes something like agreeing, okay, let me call you a cab, a fake phone call, or maybe sometimes somebody is still insisting on driving, but maybe you can't find the keys, or maybe something, oh, your daughter's coming to pick you up, sometimes involving grown children. It's a lot of white lies, and it's a lot of sort of putting it off. If somebody is trying to leave or wanting to go home or packing belongings, that's another thing, packing belongings. You'd be surprised how even just getting rid of a suitcase, so when someone goes to pack, they don't have anything to pack, can help to lessen that behavior. Or the classic sort of coat and purse by the door for ladies. I see this a lot. I used to work in assisted living and nursing home, and I'd see somebody with cognitive impairment kind of wandering around carrying her purse. She's going somewhere. Because women, when we have our purse, we're going somewhere. So I'd be like, yeah, the purse. Or same thing with people packing their bags. And if you can get rid of what they're packing into, sometimes at least that's a piece of it. It's not going to totally extinguish, but you want to find, sometimes it's a little bit of this and a little bit of that to try to diffuse the situation. But oftentimes it means acknowledging and agreeing that they want to go home and offering to help them in some way. Or like I mentioned, the gentleman who's going to work, it's Saturday. Something along those lines, and it requires a lot of really quick kind of thinking on your feet. And it amazes me the care partners come up with, actually. But insisting you are home-based, I can tell you that generally doesn't work.
I feel so guilty when I become curt. What can I do to reduce the tiredness, frustration, and fear?
That's a great
Good
question.
question.
So first off, that guilt is totally overrated. And if I have a care partner that says that they never lose their temper, they never lose their patience, I just know that they're lying. That's just not right. I mean, Judy, you can, I'm sure, speak to this. Like that it to me is incompatible with being a human. That doesn't at all make sense to me. And so first off, like the guilt is overrated. I feel like the most devoted, most amazing care partners carry around the most guilt for this little pinpoint in time, relatively speaking, this little pinpoint in time, whether they lost it. They lost their you know what, as people say. But I think that those moments when we act in a way that we're not really proud of, I think that that's a signal, or that's an indicator. Like to me, that's an indicator that that person needs to find a way, and I don't know how to make that happen, but needs to find a way to get more support, whatever that looks like, whether that's a support group or whether that's a therapist, or even talking with your primary care doctor, or
all.
reuniting with someone, or all, absolutely reuniting with someone. Like one thing about Zoom and smartphones and things, like that is one way of staying connected with someone, even someone who's far away. They should really schedule. And I'm, trying to, even just for me, I have a good friend who lives in another country, like, so literally Fridays at 4, we're going to talk on the video, unless something comes up, right? Like we have lives, but I think a lot of that piece is scheduling and really taking small bits of time to get support and get help. But it's a great question, that guilt piece. And the moments are forgotten, honestly. The people who don't forget them, like, are the care partners, but probably your spouse long forgot about that.
What are some proven non-pharmacological ways to deal with daily anxiety?
Oh, anxiety in particular, one of my favorite topics. So in addition to the things that we talked about, like setting someone up for success as much as you can, to acknowledge the anxiety, not to say there's nothing to be upset about, but to acknowledge the anxiety and help that person through it. A lot of the anxiety piece in the moment are those physical symptoms. So things like shortness of breath, or perceived like an air hunger, or feeling like I can't breathe, like I'm gonna pass out, like I'm having a heart attack, all of these things. It's a long list of things, but to literally don't underestimate the power of sitting and breathing with someone, and not like not that deep breathing that people tend to do, but like literally something like box breathing, like the therapists teach box breathing. So inhale for whatever you choose, 3 or 4 seconds, like inhale for that number of seconds, say 4 seconds, hold it for 4, exhale for 4, hold it for 4. And I literally sit there with someone and kind of draw it, and it comes down. But don't underestimate the power of being present with someone and acknowledging that validating that they feel anxious, and that it'll pass, because it always passes, and that you'll be there with them while it passes.
So if it's the care partner that's feeling anxiety, which I can easily imagine. I mean, what about things like meditation and tapping and I don't know what else.
Absolutely. Yeah. So, and depending on an individual person, right? I have plenty of people who say, I can't meditate. Like, I can't. Like, I get that, right? Like, I can't turn off my brain to do that. So, a piece of that is finding what works. And maybe that's something like yoga, or maybe that's something like music. That's another thing. I should have put something about music in my talk. Music is incredibly powerful. And however much even someone with advanced cognitive impairment recognizes music, but for all of us, that can be quite powerful. If there's a way to get in a walk, that's another like refreshing thing that can be really helpful. That environmental change and just getting that little bit of exercise, right? That little bit of a rush, right? Like really positive neurotransmitters that we get when we do things like exercising. So there's really no kind of hard and fast one size fits all. It's really what works for them. But I will say, try not to get caught up in the amount of time that you have, right? Because even 5 minutes, hopefully you have longer, but even 5 minutes to flip the script and to do something that relaxes you has benefit. I think sometimes people think, oh, if I don't have 30 minutes or an hour, it's not going to work. And that's really, and for some people, it's prayer. I hear that a lot from my patients and family, some sort of spiritual piece. So it's really whatever works for that person.
How do I deal with the spouse's denial of his condition and capabilities?
Yeah, that's a really also another good question. So that's the piece that don't argue. So that denial, I'd like to think that that's actually like loss of insight, that literally comes with cognitive impairment, where people just part and parcel that people are unable to appreciate the challenges that they have. Like, and sometimes people describe it as like people who forget that they forget. And I will ask my patients, I'll have someone just as an example who, has just really bad cognitive impairment, needs help with everything, dressing, bathing. And I'll ask them, what do you need help with? Is there anything that you need help with? No.
Hmm.
Like a really honest no, because in their perception, and maybe this is protective, like this is how I tend to be a silver lining every cloud kind of person. But it is a bit protective that the more that someone declines cognitively and functionally along with it. So with cognitive impairment, oftentimes the worse off they are, the less they realize. And so maybe that's protective to not have a full awareness that you need someone to help you with basic things like toileting and such. So I encourage my care partners to maybe reframe it, because it sometimes denial for a lot of people has like a negative connotation, like it's in denial or something, but really they just don't see it. And so in that case, that's something doesn't make sense to argue. If somebody can't appreciate what they need, then that's how it is. And so it doesn't make sense to argue, but to just sort of, oh, let me help you with that. But in some, as much as you can, some like encouraging, get more bees with honey. Let's do this thing. And really not, if they say they can do it by themselves, okay, and proceed to help them. It's okay if they don't see the need for it. But that's one of the really frustrating pieces about cognitive impairment, is that person doesn't realize how much help they need. And they can often be angry at the person closest to them for helping them. So it can feel quite unrewarding at times, especially if you're encountering that level of resistance and disagreement. You're trying to help someone.
Here's another one. My partner with PD gets up frequently at night. He's anxious about wetting the bed, so he gets up every 2 hours to pee. No frequency issues during the day, however. Cut off food and liquids at 5 p.m. He wears Depends. He's unsteady and confused on his feet during the night, even with a walker and supervision. Also, I don't want to supervise every 2 hours. We both need to sleep.
I feel like I have literally heard this scenario
Mm,
almost word for word many times. That's a tough one. So in terms of the urology piece, sometimes the urologist and the neurologist can be helpful with that. But that being said, I mean, there are some medications and such to help with like overactive bladder or like a big prostate, prevents men from being able to fully empty their bladder. So there are those sorts of things. And some other things that we recommend just in general, like sometimes someone will have like swelling or what we call edema in their feet and ankles. And then when they go to lie down at night to sleep, because if somebody's been sitting all day, myself included, right, sitting all day, we tend to hold fluid, right, in our feet and our ankles, like that welcome to gravity. And especially with Parkinson's, oftentimes people, aren't as active walking around and the things that make the muscles pump. And so they just accumulate lots of fluid. And then when you lie down, gravity, it's like in your favor, right? And so all the fluid comes in, and then our kidneys work overtime when we're sleeping. And so there's this combination of all of a sudden, overnight, someone has to get up multiple times to urinate. So some of the things that we recommend, it's not like a total cure, but during the day safely, it's a big challenge, right? But to elevate feet. So in the evening, so like if you are watching TV, if you have a routine after dinner, something like, elevating the feet, definitely keeping off of the fluids. And sometimes, I mean, it's a hard, it's a hard that every 2 hours. But those are some of the things just to try to minimize how much urine is in the bladder. Sometimes we use like a bedside urinal. A commode can be a little bit controversial because sometimes somebody could trip over the urinal. But sometimes, trip over the bedside commode, but sometimes like a bedside urinal, but it can be hard for some men. Some men to use those. Yeah, that's a tough spot to be in because if somebody has dementia, then as dementia progresses, oftentimes, people do have incontinence overnight, right? Like good news, bad news. Because at this point, if somebody's getting up every 2 hours, they have the wherewithal that they need to use the restroom and they're getting up. So, but the bad news is not sleeping, but then as cognitive impairment progresses, people oftentimes don't get up and they become incontinent overnight, but that means, cognitively things have changed. I wish I had a better answer for that. We talk about things like good lighting, making sure that the toilet is really evident and that there's a direct path to the toilet, like knowing that somebody, if they're going to get up and if they're going to insist on getting themselves there, to try to make that trek as safe as possible. So maybe those are some motion lights as somebody is going or get out of bed. And I 100% support not getting up every 2 hours with the other person who needs to get up to urinate. And I suspect that's a bit of debate. You don't want your loved one to fall, but that's not sustainable to have that level of sleep.
Is there some kind of catheter that's not invasive,
They do make a condom catheter.
Yeah, that's what I was thinking.
Yeah, they do make those. Yeah, in general, and I really can't say as a woman, I don't really know why more men don't use those, but they seem to not want them. Yeah, and even if the care partner reassures them, like it's okay to go, you don't need to get out of bed, you're wearing it depends, but oftentimes people still want to get up. I feel like that's
Well, you've got the
drive.
urge. Yeah.
And that preservation of function.
Yeah. Mm.
Yeah, that's
Okay. Next one. How does the caregiver know that they need weekly or daily help? And what are the ways that the caregiver can support the independence that, wait a minute, this isn't making sense. What are the ways that the caregiver can support the independence that the caretaker wants? I'm not sure. That's a little confusing to me.
So I'm not entirely sure, but in terms of independence with activities of daily living, so things like dressing, just as one example, to literally put out for your person exactly what you want them to put on. And when they go to bathe, swap out the dirty clothes and put the clean ones there so that when they finish, whatever they're kind of doing to get ready, they're the clean clothes, or they get up in the morning and they're clean clothes, not seeing the dirty clothes from the day before to put them on. I've had, if someone needs like incontinence briefs, like literally to switch those briefs, like the kind of pull-up briefs, switch those briefs out for underwear. Like if underwear is just not an option anymore because of difficulty with bowel or bladder, literally put those in the drawer. But the idea is to really simplify, or in the closet, only have the clothes for the current season, or no access right now to winter jackets and such. But these are like basic ways, and I talked about simplifying the bathroom, that we help someone. And then in terms of I think what you're asking is having a caregiver come in. It's very much that if the care partner, how I formulate it is the care partner is not able to meet their own needs while also providing the amount of supervision, like that tips the balance. That's probably not the best answer, but that tips the balance. I mean, some people have the luxury of being able to hire a professional caregiver to just kind of do fun things and whatever, just to have some free time. That's wonderful. But I'd say that the majority of my patients have more financial limitations. And so it comes down to sort of basic, like I need to go to the doctor, I need to go to the store, and I can't take him to the store, and things like that. They start to determine the interval, like how many hours and how frequent. One of the biggest things, you know, that always concerns me is when I have a really dedicated care partner and they don't even have time or ability to take themselves to the doctor, take their own medication and such. And that makes me worried for the person with Parkinson's. So sometimes I have a person with Parkinson's and a care partner in front of me. And actually it seems like the care partner is declining faster because he or she is not able to take care of their own physical health, their own mental health. Then I think my patient with Parkinson's and cognitive issues, what's going to become of them if their care partner is hospitalized or drops dead or something bad like that? So I try to frame it in terms of like, you know, your loved one's well-being, health and well-being depends on yours, right? They use that analogy like in the airplane, right? Like secure your oxygen mask before the other. And but it really isn't, it really is important. It sounds silly, but it's a really good analogy.
So some of the next question is sort of medicine specific, but the end of it is not. So would it be possible to have liquid medication by mouth instead of pills for some of the medications like levodopa, carbidopa, for a quicker uptake of the medicine instead of the duopa by pump? So I guess that is still specific, but
A good question, probably better for the neurologist, but what I can tell you is that you have to check with your neurologist, but I've heard through the grapevine that some of them, in certain circumstances, some of the neurologists recommend crushing a pill of carbidopa levodopa, not like the extended Rytary, but just the immediate release Cinemat carbidopa levodopa. There's something about that can have a faster uptake, but I've just heard that through patients. That's not my official advice. Isn't
there also a nasal spray?
That's really new. I've only had one patient be started on that. So my experience with that is really limited. And I imagine it costs incredible, or it's hard to get insurance to pay or whatever. I don't know that for a fact, but new medications, there's often a slow uptake.
I don't know. I don't know about it, but I mean, I just know it exists.
Exactly.
So now we're on to the last one. Let me see if I can limit this, if I bring it close enough to me. Germany and Sweden have restaurants with sections to bring neurologically impaired with the family to keep stimulus of regular restaurants at a minimum. Okay, so that's not a question.
I love that other countries are actually doing that. One of the things that I recommend, like within our system, is to find, so if you and your person enjoy going out to eat, to find a place that is familiar and comfortable, where they get to know you, where you have a table and you're going during non-busy parts of day, and you know that your person likes a particular thing, that basically you're setting it up so that it's just going to work out. And that can be a nice routine and like a way to kind of mark the week. I'd love that other countries do that.
Have you integrated and found effective deep relaxation and meditation into your protocol for chronic pain, given that, oh my God, I don't know whether to keep the glasses on or off. Given that the AMA now recommends both cognitive therapy and supportive meditation for the conditions of chronic pain. Cognition may suffer, but guided meditations that I have used to assist both chronic pain and morning loss of motor control and other symptoms.
Wow, that was a long question
Yeah.
/ comment. So yeah, I'm trying to think of what part to answer. I haven't, full disclosure, I haven't really done much treatment in terms of pain. It's more, I talk about the recognition of pain in Parkinson's. I mean, just pain in general, as people are growing older with conditions like arthritis and such, being so common, back pain being incredibly common, then you throw Parkinson's on top of it. I can't say I have much. I just have not done much in terms of treatment of pain. Typically, it seems like the neurologists handle that, or use different sorts of injections or things, or other modalities. Yeah, I actually haven't had much opportunity to use that, so I don't know.
So I think we're done with the questions.
Okay, and there were
Does
a couple in
anybody-
chat, but I think you did those.
Does anybody have anything else that they want to ask in the chat?
Is anybody actually still on?
Yes, yeah, there are. There are.
Big group.
Not as many as started out, but they're still.
Yeah, I'd have been like, that's enough.
Well, I hope everybody I thought it was a terrific talk. I enjoyed every minute of it. So thank you.
I appreciate that. It's my first iteration of this talk, and thank you so much for
Thank you.
inviting
Thank
me.
you.
I'll keep tweaking it and give it again. So
And hopefully we don't have any more internet issues around here, because that was a pain in the neck.
you're nice and smooth since
Now, not in the beginning, but now, yeah, finally. So anyway, thank you everybody for coming, and thank you for registering, and thank you for submitting questions. And remember that this is recorded. So if you didn't get to see it, or if you want to see it again or see certain parts, it will be on the website, I would think by the end of the week. So,
wonderful, great.
okay, thank
so
you.
much.
Thanks. Thank you. Good night.
Thank
Good
you.
night, everybody.